fantastic virtual annual scientific meeting, and especially for you, John, and also for Paul Bollet. Thank you so much for putting this excellent program together in such a short time. So I have a message here that I cannot, oh no, it's working, I think. Let me just see here. Yes. Okay. All right, so it's a great honor for me to give this overview talk about femoroacetabular impingement. And let me get to my first slide here. So femoroacetabular impingement, these are my disclosures. I believe most of you are very familiar with this concept, which has been published by Reinhold Ganz and his co-workers in the year of 2003. We have two main aspects. One is the cam impingement on the femur side and the pincer FAI on the other side. Over the past years, we were hearing lots of information about femoral retrotorsion, and meanwhile, retrotorsion is considered as the third column of FAI, and it can either aggravate or compensate cam or pincer FAI. On the femoral side, cam FAI, it has different causal pathologies, either local ones such as a head-neck asphericity, pistol grip deformity, and more global ones such as skiffy and a reduced antetorsion, as mentioned before, retrotorsion. So this is the classic radiographic view. What we get from a lateral view, you see here this significant cam deformity at the anterolateral head-neck junction. And this is how it looks like during a surgical dislocation. On the other side, on the acetabular side, the pincer FAI, also here we have different causal pathologies, local ones, global ones. The more local ones are local overhang, overcoverage, and it becomes more global when we have to deal with retroversion and a coxa profunda or protrusio. This is the classic pelvic X-ray of a retroversion of the left acetabulum. You see here the positive crossover sign. This is a classic example of a over coverage of the whole acetabulum with a pathologic LCE angle, and this would be the maximum version with additional ossification of the acetabular labrum. There has not been anything else over the past 20 years, I think, which has influencing joint hip preservation surgery as much as FAI. When you look at the publications of the past 20 years, you see how dark the years previous to that must have been. The important questions also in order with respect to our presentations today is what do we know and what don't we know? There are several aspects such as the pathogenesis, how and why does FAI develop, pathomechanics, morphology, what is causing damage? The question is it really leading to osteoarthritis? Imaging, what is needed when? Important question, can we make the patient better by surgery? Arthroscopic versus open approach, what is better? And finally, can we prevent or delay osteoarthritis by surgery? I would like to go over these questions and start with the pathogenesis. Nowadays, we know that the cam deformity is not present before adolescence, and this has been shown by different papers in the past. We also know that the risk for development of a cam deformity is higher with high-level contact sports during adolescence. You see here at those papers that the alpha angle is significantly increasing when you do high-level contact sports during adolescence, and the risk is higher for males. There are other factors responsible for development of a chem deformity. There are some indicators that we also have genetic, social factors, a higher risk in siblings. Generally, there's a higher risk for chem prevalence in males. Sequelae of pediatric hip disease, SCIFI, for example, and Perthes disease. Retrotorsion and post-trauma conditions. Femoral retrotorsion is an important issue, and we know also that the head-neck junction can be deformed by trauma and fracture, and this was one of the conditions that Reinhold Ganz and his group observed in the 90s when they came up with the concept of impingement. We know much less about pincer impingement, the development of pincer. It has been shown that there is also a higher risk in siblings. There are probably also some genetic aspects. There may be a relationship between some genes and acetabular coverage, which has been shown in Japanese individual. And there's probably also a little higher tendency for pincer FAI in females. Iatrogenic post-surgery, especially acetabular reorientation surgery, can lead to significant pincer FAI by causing retroversion. There are also developmental issues. We know that the version is increasing during adolescence. Consequences, I think it's very important that we consider reducing intensity and high-level sports during adolescence in order to avoid formation of the chem deformity. Whereas one presentation today, one presentation is about how does chem FAI develops in athletes. We're looking forward to hear that later. What is causing the damage? We have two mechanisms in chem FAI. We have dynamic overloading. Bringing the head-neck junction into the socket is causing primarily a cartilage damage here at the anterolateral rim, whereas in pincer FAI, because of the overhang of the rim, the primary location of damage is the labrum. This is the nice animation by Primal Pictures, and you see how the head-neck junction is forced into the socket, causing damage here at the anterolateral acetabular rim. This is how it looks like during arthroscopy. You see the damage here at the sublabral cartilage on the initial phase, and this is how it looks in advanced cases where the whole anterolateral cartilage is being delaminated from the anterolateral rim. On the pincer side, because of the overhang, the labrum is pushed against the femoral neck. So the primary location of damage here is the labrum. And in the end, we also get cartilage damage at the posteromedial contour of the socket. Here you see the typical arthroscopic picture. The labrum is very small. We have a positive wave sign. So also the adjacent cartilage is being damaged. And this is the final stage. You see here the deep contour cartilage damage at the posteromedial ischial part of the socket. So the question is FAI leading to osteoarthritis? To date, there is a strong association for chem. However, we have no evidence so far for pincer FAI. In adolescence, there are several papers already that have been showing that also in young athletes, in young patients aged 11 through 18, we find about more than 50% labral cartilage damage, more than 80% cartilage damage also in these young athletes with chem deformity. So it's very important for us to identify chem FAI very early in order to advise athletes, maybe change technical aspects of their sports, and maybe thinking of early operative intervention. In terms of imaging, I think most of you know what is needed. Usually we ask for radiographs first, a good pelvis AP radiograph, lateral radiograph, and it's very important to take an AP pelvis and not a deep AP pelvis, because we need to be able to evaluate orientation of the acetabulum within three-dimensional pelvis. That's very important. It's not being cleared so far which technique is the best one, if we should use standing or supine x-rays, because there's a significant influence of pelvic tilt. This is also a problem in total hip arthroplasty. The impact of pelvic inclination is being also discussed and increasingly discussed. When you, for example, look at our ISHA newsletter from March, you will see a nice paper on that. So this is being recognized and should be considered in the future. Lateral projections, there are different lateral projections out there. I think everybody has a preference here. We for example, prefer the Lauenstein view. I think in Switzerland and many English-speaking countries, the Kostrabel view is preferred. False profile view. The false profile view, in our opinion, is very important in pincer FAI. Here you see an AP pelvis of a pincer, a left hip joint. You would say, okay, this is a good hip to proceed with arthroscopic treatment. However, when you take the false profile view, you see already the incongruency of the joint with significant narrowing here of the joint space at the posterior medial joint. So this is not a good hip joint for hip preservation anymore. I recommend you, there's a great paper here from Moritz Tannast about all the measurements that you can do. I think that's very important to establish a standardized analysis of x-rays and other imaging procedures. High resolution MRI, I think no question, we need high resolution focused MRI of the hip joints in order to see where the labral pathology is, where cartilage deformity is, and also where our cam deformity is located, in order to plan operative treatment. Difficult question is, should we always need arthrogram? I don't think so. We like to see if there's an effusion synovitis. In the specific questions, we recommend an MR arthrogram, and you also have to consider that there may be also disadvantage from intra-articular contrast media application. Traction MRA is being discussed, and this shows higher sensitivities and specificities, especially in order to detect control flaps at the contralateral junction. It's very important that we get three-dimensional views. FAI is very often combined also with other problems. Very often it's difficult to really assess the conflict. So it's nowadays, I think it's mandatory if you measure version, and you also need to torsion of the lower extremities. So it's very important that you combine your pelvic slices with some slices at least through the femoral condyles in order to assess femoral torsion. Cartilage imaging, it's very difficult on conventional MRI to assess the cartilage if it's only changed, like here, like swollen. If you have a positive wave sign, it's very difficult to see that pathology on a regular MRI. So they are biochemically sensitive techniques that can be considered. However, in the radiologic field, in the orthopedic field, I think this technique is not yet established, and we need to further work on that. CT can be very helpful, especially when you have difficult cases, such as in this case here. So the question is here, for example, can we remove this part, or do we have to refix it in order to avoid instability? And this is very important in difficult cases. We can get three-dimensional views, three-dimensional simulations from MRI and CT data. So this is also one of the topics of our lectures today. So we will have some lectures on soft chem lesions. We will have lectures on model printing from 3D data sets. I'm looking forward to hear that later. The question, important question, can we make the patients better by surgery? The basic question is operative versus non-operative treatment. And there's a recent paper just came out in arthroscopy, and the message is, yes, we have superior hip-related outcomes in the short term by operative treatment compared with patients that were treated with the physical therapy alone. Also, in adolescents, the analysis of the literature shows that we have good to very good results from operative treatment. And one important message is there's likely no recurrence of the cam deformity. The question which has been influencing us, especially on the first 10 years after first publication, is which treatment should be preferred, arthroscopic or open surgery? I think we can discuss that for hours. I think the basic message is both operative approaches are leading to good results. This meta-analysis has shown that probably the only difference is that the arthroscopic method has the lowest complication and the fastest rehabilitation rate. Also, we have two presentations today about this surgical hip dislocation versus arthroscopy and long-term results from Italy, Milano. Last question is, can we prevent or delay osteoarthritis? We don't have a lot of research on that. I think there's only this study here from Paul Bollet's group from Ottawa, analyzing 13 patients with a surgical dislocation for FAI. And what they showed is 1 or 2 years after surgery that the cartilage is stabilizing and that the bone mineral density is decreasing, indicating a decrease of stress to the anterolateral rim. Final question is, prophylactic surgery in asymptomatic patients, is that indicated? No, we don't have any evidence to prove that, so we have to wait for such studies in the future. Conclusion from my side, I think FAI is a very complex pathology. When I look back onto the first years after publication, I think it was quite easy, but the more we are finding out, the more difficult and the more complex it is becoming. Thank you so much for your attention.